Welcome to Care Transitions Today. This podcast is being presented by the American Case Management Association, and it's being underwritten by the Pfizer Foundation. I'm your host, Deb McElroy, and in this episode, we're going to be talking about lasting changes in Medicare as prompted by COVID-19. I'm happy to welcome today our guest, Pat Kramer, a very valued member of the American Case Management Association. She has over 30 years of experience in the evolution of hospital case management. She's worked in acute care hospitals in Kentucky, Virginia, and North Carolina. I'll let her tell you a little bit more about herself, but I just want to mention that she is a past member of the National Board of ACMA, and she remains active at that national level for ACMA as the chair of the Public Policy Committee. And that's going to be the perspective that she brings today, which I'm excited about. She is also a past president of the North Carolina chapter, and it remains involved there too. So really getting that experience from Pat, as well as her perspective from her work with the National Association. Pat, I'm going to toss it to you. Can you tell us a little bit more about yourself, your current role, and we'll give it a go with our podcast today.
Thank you, Deb. Yes, I am Pat Kramer. I'm the Senior Director of Case Management, Utilization Management, and Clinical Social Work for the Duke University Health System in Durham, North Carolina. And I have been with Duke for 15 years and have watched all the changes that have come about as a result of COVID in the past year. My work this year has been focused a lot on probably three things. First and foremost, staff support, as we've had to make some changes in how we do part of our job. Some of these changes were allowed because of some of the waivers, the 1135 waivers. The other major focus for me has been working with our skilled nursing facilities in our region. And then the third focus has been working with the homeless population in our region. So those three things have kept me going since March. And I'm really excited to be here today. I realize I can't keep my own experiences at work out of this, although I do want to make a point that I'm really here representing the ACMA Public Policy Committee. And any of the viewpoints that I expressed today are my personal thoughts on things, and I just want to make sure that that's really clear. I'm not really representing Duke's perspective.
Okay, that's perfect. Thank you.
So hopefully that makes sense.
Okay, so you talked about sort of in your role those three areas, and I today. I think that's a great foundation for our discussion. I want to talk about that because I think folks are interested in that. And then, of course, because it's the topic today, we really want to get a sense of what the committee members on the Public Policy Committee are experiencing in terms of the changes to Medicare and just thoughts on what we think is coming in the future. This is a difficult time to be talking about it the month before the election, but interested to hear what you have to say. So if you want to just touch a bit on staff support as you're talking about your role, let's just get a little bit of a flavor for that, and then we'll dive into the CMS issues.
Okay, thank you. So I mean, one of the things that we were asked to do, actually, at the very beginning of the pandemic, back in March, was to put any of our staff who we felt like we could deploy to a work from home setting to preserve PPE, because at that point, if you remember, we had shortages all over the place. You know, as case managers, we are obviously going into the patient's rooms, so it was going to require full suiting up. And so the question was kind of put to us as, is there any aspect of your job that could be done from home? So we deployed some people to home. And as the summer went on and things started stabilizing, and luckily in our state, we did not have a spike during the summer. So we were asked to bring people back. So then it was like, you told us we could go home, and now you're bringing us back. And we had to make things safe for them. So teaching them how to not only talk to patients through face masks, but now shields, face shields are even required, giving them office space where they could be socially distant, the 6 feet, of social distance space requirement whenever possible. I mean, so it was things, like that. And then supporting through their fears. And we had some of our clinical social workers did a brilliant job of doing like tea time with anybody who wanted to participate, and just doing some supportive counseling, some ideas on wellness, things like that. So I think that really helped. The staff know that we as the leaders care about them, that we were taking their safety needs into account. What I alluded to when I said, and some of the waivers helped with this, was the waiving the requirement to have the choice form presented for choosing home health agencies and skilled nursing facilities, for example. So because our habit was to go into the room and present that form in person, share the quality data, the requirements of the Impact Act. And so we were able to waive that requirement. So that really helped again in allowing some people to work from home and allowing others who are on site to not have to go into the room. So again, to be able to conserve some PPE.
Yeah, great. Well, just an observation that much of what you're talking about seems to be a theme in the folks that we're talking to on this podcast. And certainly, I think we'll be able to see what implications that has for the future. So you talked about some of those waivers and stabilizing the environment related to the pandemic during the summer. We're not sure what's coming up in the fall. So as you think about where you're at today and what you immediately are planning for over this next late fall and early winter timeframe, can you comment on what you're hearing from the Public Policy Committee on their, planning efforts? Do you see the waivers continuing? Just any perspective on that as we dive into this issue?
Whether I see the waivers continuing or not, obviously, I think depends on the outcome of the election. What happens, and I don't dare speculate on that. But what I'm hearing from the Public Policy Committee is one of the things that we've talked quite a bit about is how are they using some of the waivers. And that varies from one part of the country to the other, to be honest. And partly, I think that variation is due to the difference in the rate of COVID in the areas, especially the Northeast, New Jersey and New York. Our members from that area used the 3 midnight waiver a lot. And they used it with mostly, honestly, not COVID positive patients as much as clearing space for COVID patients in the hospital by discharging people as fast as they could safely to skilled nursing facilities. So they've used that a lot. We have another member in public policy from the West Coast, and they've used it as well. I think one of the things we've heard about that waiver in particular, and we've heard it from both hospitals and by way of our members of public policy hearing what they're hearing from skilled nursing facilities, there's a little bit of a reluctance on the part of some facilities to accept patients under this waiver for fear that they may not actually be reimbursed. What I'm hoping is that as this continues, and the fact that the waiver's been in place since March, that we'll start having proof, if you will, that they're being reimbursed, so that would encourage more people to use it. I think the other thing that around that particular waiver that we've talked about in public policy is as probably most of the people listening to this podcast will remember, we've been advocating for quite a few years now to do away with the 3 midnight requirement, or at the very least count observation days toward the 3 midnight stay. And what we've been talking about is, are we going to find that a tremendous number of patients have taken advantage of this waiver, so that any fears that CMS would have that this would just overwhelm the system and that it would cost a fortune and all that? It's going to be interesting to see what really happens with that, because are that many more patients being able to do this? And one of the things that leads us to that question is, if people are going to a skilled nursing facility, presumably they really need it, so they're sick, and so are they really able to get out in less than 3 days anyway? So it's going to be interesting to see what happens with that, actually. And how much are we using it?
And I'm going to just take a sidestep here, because there is a chance that we may have an audience listening to this podcast that isn't as familiar as folks in case management are with that requirement. So if you could just give a brief description of that, and then maybe the public policy committee's previous advocacy efforts from ACMA. Just a brief description would be great.
Okay. So I think the 3 midnight rule has been in place, forever. And that requires that a Medicare beneficiary be inpatient in the hospital for 3 midnights. And these 3 midnights need to be medically necessary midnights. So you aren't to keep a patient in the hospital just to achieve that third midnight. And if a patient is in observation status, as opposed to inpatient, those days in observation don't count toward the 3 midnights, which, I mean, just, to us in case management really just doesn't make much sense, practically speaking. I mean, they need to be in the hospital. And they were sick enough that their status was changed from observation to inpatient. They were sick those first 24 hours they were here too. So anyway, I think we've been trying to advocate to have that removed for a long, long time. And I think that the efforts that the Public Policy Committee have made have been really admirable. We have advocated on Capitol Hill on numerous occasions now, 3 or 4 years, to straight with the legislative offices, especially congressmen and senators who support the bill that was actually introduced in 2011 by Representative Joe Courtney from Connecticut and Senator Kerry from Massachusetts. And I apologize, I don't remember some of the other names of the supporters of the bill back in 2011. And this is 2020, and we're still advocating for it. We did an effort at the national conference 2 years in a row, I believe, to get signatures to a petition to, I hope petition's the right word. I think it was.
It was.
To get to show as much support as possible for overturning the 3 midnight rule.
Okay, that's great. And I appreciate the description because it's an important one. And as you're thinking about the waiver, so you mentioned, certainly 3 midnight rule, but some others as well. As you look down the road or reflect on the experience that you've had and that other members of the public policy committees have had, is there anything in particular that demonstrated true additional efficiency? So 3 midnights, I think lots of folks thought this was something that needed to be addressed long ago, and ACMA has been trying to do that. But anything else that you think, okay, this was waived and boy, did it make a difference?
Yeah, I think waiving the Passar requirement has helped too. And I think the requirement is, the patient still has to have a Passar, but the nursing home can do it after the patient gets there.
Okay, so talk a little bit more about what that is. And
Okay, that Passar is, again, it's a rule that, believe it or not, I predate Passar in case management years and years ago when we were called discharge planners. This law, it's a federal law that requires patients going to a nursing home be pre-screened to rule out any mental illness. It comes out of the history of mentally ill people being, quote, warehoused, end quote, in facilities. And I think the purpose of it is certainly noble and makes lots of sense. And the way the Passar is done really does vary state to state. As you said in the introduction, I've worked in 3 different states and it's been done 3 different ways, but it always did have to be done from the hospital. So now we can send patients to the skilled nursing facility, to a nursing home, and the Passar is done by the nursing home staff after they get there. The process for the level 1 Passar is not that onerous by any means, but it does take some time. And, it takes, in my state, for example, it takes going into this portal and entering the information and then waiting to get the Passar number back. So it's not a huge delay, but it's just one more thing to do. But a level 2 Passar, which is what happens when someone does have some level of questionable mental health issues, including that someone is taking an antidepressant. I mean, it can be that simple, if you will, and that then requires this level 2, or may require the level 2 Passar. And those could take days. I mean, the people who do the level 2 Passar, it has to be a face-to-face evaluation, and that can take days to schedule. So if someone does need a level 2, they're in the hospital for extra days every time. So the fact that can be done, now that does have to be done before the 30th day of admission in the SNF. But again, it can be done after discharge from the hospital. That, I think, is a huge help and makes sense. So that one, I would love to see that one continue too. So that's 2 that I'd be really happy if they go on. I think the other thing that I know some people have on the Public Policy Committee have mentioned they've been able to take advantage of is the temporary certification for beds in the hospital to be changed into skilled nursing facility beds, like swing beds, for example. And that some people have been able to do that so that when they are unable to place their patients in a skilled nursing facility for whatever reason, they're able to put them in the new skilled nursing unit of their hospital. And those patients can be rehabbed and taken care of at a lower level of care in the hospital. There are some differences of opinion maybe in the Public Policy Committee on how that's interpreted. There's a phrase in the waiver that said people who are otherwise affected by COVID. And so some people are interpreting that phrase broadly, and others are interpreting it very conservatively. And that makes a difference of whether whether a facility is likely to open one of these alternate care units or not, really is based on how they're interpreting some of the wording in the waiver. So I think that's kind of been interesting too. Some of the waivers around home health are very helpful as well. And one of them has already become permanent, actually. And I think that's going to be really helpful. And the permanent change that actually happened pretty quickly was to allow nurse practitioners and PAs, physician assistants, to certify for home health. And they can now order home health services, they can sign the home health plan of care, and they can certify and recertify that the patient is eligible for Medicare home health services. So that is very helpful. I think the other waiver that became a permanent change is the increased use of telehealth to provide needed services in the home health arena. And the home health agencies can now provide more services to beneficiaries using telecommunications technology, including remote patient monitoring, telephone calls that are audio only, so no video included in that. Some things still do require two-way audio video technology, but I think as these improvements have been put into place, I think that really helps more people be able to take advantage of telehealth. Before it was limited to people in maybe a rural community, things like that, and now it's really open to any beneficiary who needs home health.
I'm curious, Pat, as you're talking about some of these changes, would you comment on whether you think there was, I'm trying to think of the correct phrase, but pent-up demand for some of these changes? Do you think the sort of the practice of case management was ready for these waivers to come into play? Certainly there's been some advocacy efforts, for a few of them, but it's sounding, as you're discussing, that there's some opportunity to standardize what this looks like across the states, but that by and large they have contributed to efficiency.
Yeah, I think it was case management ready for these waivers. Absolutely. And I feel like we've, as a profession, just been able to keep pace with the changes by adapting really quickly. I think some of the things that I'm seeing were things that we've talked about just in the Public Policy Committee, talked about, in other settings of, they're reasonable, they make sense. And they're maybe, I would even venture to say, more patient-focused, patient-centered, because, for example, the homebound definition, that's been expanded. Now, this is still a temporary change. This hasn't been made permanent yet, but the homebound definition has been expanded to include if a physician advises a patient not to leave home because of a confirmed or even suspected COVID-19 diagnosis, or, and this is huge, if the patient has a condition that makes them more susceptible to COVID-19. So that really relaxed the homebound requirement and allows more people to get the skilled services they need under their Medicare home health benefit. So I think that is an example, again, of something that, we've said over and over again makes sense. And it certainly is definitely patient-focused.
It's great. One of the things as you outlined your focus at the beginning, you talked about skilled nursing facilities or SNFs, and certainly you've woven that into your past few comments. There was some funding that was announced, and I just wondered if you wanted to make a comment on this. There was CMS had announced some new federal funding, 33 states. North Carolina, it specifically was not one of them, but it was supplemental funding for the Money Follows the Person, so MFP program. And it made available $165 million additional dollars to those states to focus on transitioning individuals that are in skilled nursing facilities back to the community. It's an existing program, if you want to comment on that. But I think trying in a COVID climate to see if we can increase capacity in the skilled nursing facilities, I'm assuming, and sort of probably impact acute care as well. And then I'm just wondering if you've seen any similar programs in your region.
Sure. So, I think unfortunately, the additional funding that you're mentioning had not come out when we had our last public policy committee meeting, because I'm really anxious to talk to the members of the committee from other states, since North Carolina did not get these funds, to see how they're going to see it making the best use in their state. But, I can think of reasons to do that, to allow patients to be discharged from skilled nursing facilities with additional support in the home, to free up the beds in the skilled nursing facilities. As if COVID does spike again this winter, we're going to be really in need of being able to decompress the hospital as quickly as possible and get patients to the skilled nursing facility. But if they just sit there, then that doesn't really help, except the one time, the first time we send somebody out. So we need to keep the throughput going. So I think if we, any additional funds for that program does have some pretty significant, I'll use the word restrictions for lack of a better word. It's applicable to certain people. I mean, everybody doesn't qualify for it, in other words. But the ones who do, I think that's great. And to me, that's just one more sign that CMS is really looking at the patient and what makes sense for the patient. And that gives me hope. That really does. Because some of the regulations that are in place just seem so illogical that if you're the patient or the family, and they just don't make sense. So seeing things like that happen, again, give me hope that they're actually focusing more on the actual needs of a patient. Other funding things that I've seen, in one thing that we do have in North Carolina that's really exciting, and I don't know how many other states might be doing similar things. The Department of Health and Human Services in North Carolina is using some of the CARES Act money to provide some concrete assistance to people who are impacted directly by COVID, if they are COVID positive themselves, if they are a family member of someone with COVID, if they are obligated or recommended to stay in because of other conditions that make them more susceptible to COVID, or that make it more dangerous to them. And the funds provide for home delivered meals, transportation to the pharmacy for meds or to a doctor's office. The certain patients, one of the beauties, I'm getting a little sidetracked here because it's an exciting program. One of the things that's really cool about it is this money is available to anybody, and they don't have to prove income. They just attest to it, but there's no need for paperwork, which slows things down. There is actually no citizenship requirement even for the meals and the transportation assistance. There is a monetary allocation also for people who do qualify financially, but even that qualification is an attestation from the patient. Hopefully they're telling the truth and they need the money, and it's $800 and it's available pretty much immediately. It's designed to be used specifically for people who are out of work and not getting paid because they're not working. So, people who have no sick leave, that kind of thing, and they've been told to quarantine, or they're actually sick, and they have the need to stay home. And we've actually seen cases where people's utilities are cut off because they can't pay their bill that month, or they're about to be evicted because they don't have rent that month because they're not working. So they can actually get cash. I think most people are paying the bills as opposed to giving cash, but yeah. So I think that's really exciting. And I'm sure other states are doing similar things. And again, I can't wait to ask on public policy what other things people are hearing.
That's great. And just to clarify, that's a one-time.
As a one-time, absolutely.
Payment.
Yeah.
So it's sort of that immediate emergency.
Absolutely. It's a stopgap for the few weeks that you're Yeah. I mean, and it's all really based on having to quarantine for 2 weeks.
Got it. So direct response to COVID,
Yeah,
which is great. I'm going to go back to sort of the outline you gave us at the beginning, and you talked about a focus on the homeless. And so I'm just interested to hear your perspective, anything you've heard too from the committee. I know in a previous podcast with our folks from Houston, they were talking about that population being so challenging as well. So can you share what your experience has been?
Yeah, it's really been interesting because the different counties are handling things differently throughout my state. And I'll really just talk about North Carolina right now because that's obviously what I'm the most familiar with. In some counties, we've seen hotels set up almost immediately as shelters had to decompress, and some even closed. For people who, one county, for example, that I'm familiar with, set up a well hotel, if you will, and a COVID positive hotel, so that people were not in shelters who had COVID, and then when shelters, say a shelter has 100 beds, but those are pretty close together in a room or several rooms, and they have to now socially distance the patients. The residents. So now they can only take 40 people instead of 100 people, whatever. So where were those people going to go? So rather than just discharge them to the street, again, this one particular county stepped up to the plate very quickly and established these hotels. They worked with the county emergency management people to provide meals, to provide mental health services. They worked with our the LMEs to provide mental health services. They had medical care needed. They had nurses who could go in from the health department. So they just partnered with all the agencies in their county. It really worked well. Some counties haven't been that fortunate and haven't been able to get all the pieces in place yet. But I think it's been a really interesting picture of, first of all, caring for a very vulnerable population, recognizing that not providing this level of care to this population would be disastrous as far as the spread of the virus, and acknowledging that it takes everybody. I mean, this is the government agencies in these counties, as well as the not-for-profit agencies, the health systems, coming together in a way that I'm sure is not unprecedented, but was still really gratifying to see. And it's been fascinating to watch how it's come together. And I work in an area where there are several counties involved in our population that feeds to our health systems, 3 hospitals. So, I've been able to see how different counties have been able to pull together their resources. And it's been interesting from the perspective of, I guess, just looking at the systems that have had to come together. And I don't mean health systems, but the community systems. And then, but also, I think just watching the compassion that I've seen and the just acknowledgement that we have to take care of the whole person. I mean, it's been physical needs, it's been mental health needs. I've gotten personally a lot out of the work focused on this population this summer.
That's great. And as we have had a number of these discussions, I think those partnerships that may have existed already but are strengthened because of the acute nature of this pandemic. Any observation or comment on any provider organization? So, how you've integrated with sort of the physicians in your system, either employed or or maybe independent. I'm not sure what your system looks like or throughout the state. But again, obviously important partners along with the public health folks, the county folks, the acute care.
Yeah, I mean, I think, my health system, the providers in my health system have again, I don't think I've ever been so proud to work anywhere as I've been this summer, to see whatever the providers, the nursing staff. I mean, it's been amazing to watch the things that people have volunteered for, to work at testing sites, to stand up testing sites, to distribute masks, I think, again, just watching the willingness to share resources at a time with the homeless population, with skilled nursing facilities, to step in and help them when they were in a crisis. Again, with just testing support, and it's just all of that has been remarkable, and not only remarkable, but again, very gratifying. Very, it just makes you really proud to be in healthcare at this point. It's a terrifying time, but it's a time to do what people have been trained to do, and and that's what I think. As I've reached out to some people I work with to just say, thank you so much for what you're doing and the remarkable work you're doing, and only to hear back, it's exactly what I was trained for. There's nothing remarkable about it. It's what I do. And I mean, that's just so, again, it just makes you proud.
Well, I would echo those statements. Not involved in your particular health system and sort of standing on the side, but just applaud and appreciate every single effort that is taking place as we navigate these really difficult days. I'm going to go back to really the role that you're performing, which brings you to the podcast today, and that's chairing the Public Policy Committee for the American Case Management Association. And can you talk a little bit about sort of the purpose of that group and what you see as the role now and maybe moving forward, again, as you help members of that association and members of our broader healthcare community understand what our next steps are, and then specifically for the CMS waivers, how are you envisioning your response to that? So 2021, which I can hardly believe is right around the corner. So what is this group thinking about?
So the Public Policy Committee has numerous goals. And one of them, I think, I already mentioned earlier, is to advocate for changes to the 3 midnight rule. And that's something, I feel like I pretty much covered that, and we've been working on that for a long time. But I think where I feel like the Public Policy Committee can really help this year, maybe in a slightly different way, is because we all work in the business, so to speak. We're watching the impact of these waivers, and we're seeing the ones that are really either directly helping the patient or increasing efficiencies in our hospitals, which indirectly impact the patient. But if we can use our voice, and we have a very well-respected voice in Washington. We have, I think we've presented ourselves very, very professionally, and we are seen as very knowledgeable. So I think if we can combine, our efforts again and get down on paper even, how the waivers have helped, again, both the patients and the hospitals, I think we can make some good points with that, and can share that information in the right places to have, I hope, a lasting impact. I think, again, the value of the Public Policy Committee, in addition to what I've already said, is that there are people from all over the country serving on this committee, so that we have differing viewpoints and differing success with using some of the waivers. So I think that kind of varied experience is going to give us a perspective that I just can't help but think is going to be valued, because it's a broad perspective. And so I hope that we'll be able to use that information to help move some of these things into a permanent status. That's my hope.
Yeah, sort of leverage that perspective.
I think the other thing about the Public Policy Committee that I want to make sure I mention is we are available to talk about public policy at chapter conferences, and are more than willing to do that. There's one coming up soon, and I know we're on the agenda for that. And then I think we normally present at the national conference too. I think I'm already slated to do that actually in April. So, because I think the one of the big values that the Public Policy Committee brings to ACMA is our role to educate and to, because, I think some people, case managers are very busy people, and they're doing their job every day. And they know the conditions of participation, and because they learn that in orientation, and they realize how those things impact the performance of their job every day. But it's hard to keep up with all the changes and I think some people don't even realize that they can have a voice if they want it. So I think, again, the Public Policy Committee educating and showing people that we have a voice that's heard. I think there's a lot of value in that.
It's, I think, valuable for folks to hear, and even those who are not members of ACMA really understanding that there's a vehicle even on the website to better understand some of these key issues. I don't want to let this opportunity, with having you here, I don't want to let this opportunity pass by without asking about some of the things that were on the horizon at the beginning of 2020. Obviously, intensity with COVID, and there is this focus on the waivers, but there were some other issues that were being considered in Congress, surprise billing, some other issues related to healthcare that were on the agenda. I'm not sure if that's relevant now, and the election may sway where that heads, but and the answer may be what's in front of us is what's in front of us. But is there anything else that you can think of that was going in at the beginning of 2020 that you were thinking might have been a key issue that you think will resurface as we start 2021?
Well, I'm glad you asked that question, because I think there is something that is definitely remaining a topic through the COVID pandemic that is going to be enduring, and that's the social determinants of health. And that was certainly something that's gotten a lot of focus. And that's one of the goals of the policy committee this year as well, is to understand how we're going to educate people about it, and understand how we're going to begin to meet those needs maybe in a different way.
So I'm going to give you the opportunity to educate right now. So social determinants of health is a phrase that I think if you're in case management, you're familiar with. If you're listening to this podcast and maybe not in this discipline, can you just talk about what that means and the kinds of things we're thinking about? And you've alluded to it as we've talked today, but.
So the social determinants of health are actually, if you know my background, I'm actually a social worker by background. And, and I think a lot of social workers would say, this is not news to us. And a lot of case managers, whether they're nurses or social workers, understand this is not news to us, that these things impact outcomes, health outcomes. And by these things, I mean things like housing, food insecurity, violence in the home, where somebody lives, and the services that are available in their community, social supports, either there or not there, education. I don't remember if I said that already or not. And not just education related to health related topics, but education in that your education level may dictate your employment. So, and your employment may dictate things like that we've talked about already with related to COVID. Certain jobs don't have sick leave, for example. And, if you have more education, you're possibly more likely to have a job that has benefits. Do what kind of medical coverage do you have? All of these things absolutely have an impact. One of my favorite examples to use, I think, is one it's near and dear to my heart for some personal reasons, but also one of the people that I work very closely with works in the field of managing patients with diabetes, endocrinology. And, we evaluate a patient in the hospital. They have uncontrolled diabetes. We set them up with, a diet. We set them up with possibly an insulin regimen, let's say, and send them home. And when their home is someone's couch this week and someone else's couch next week, or they're in, they don't have any food in their house. So the diet we sent them home on goes right out the window because they don't have any food, or they live in a food desert, another term that has come to light. Again, I think we've known it, but now it has a name. Some of the neighborhoods in our communities that only have fast food markets, for example, and they don't stock fresh vegetables and things. So we know as case managers, if we send someone home and don't address those needs, they're going to be back because they have to fail. They can't succeed because we haven't helped them by helping them meet these needs. So I think just the fact that it has a name now, social determinants of health, it's taking a lot of, it's getting a lot of attention. In North Carolina, I know we're mandated now for Medicaid patients to address these needs. We've partnered with an organization, I won't name it, it's a platform that allows us to make referrals straight into it that then we can track so we can close the loop to see if people actually followed through on the services that we set up, which is going to be great. So we're looking forward to starting in that. But I think that's a big issue this year that I think is going to continue. It has to continue, I think, regardless of what happens next month and whether or not COVID continues to be an issue with us or not. It's ongoing.
Yeah, and I would point out that I believe that really was as part of a policy agenda, not just individual health systems or individual communities, but really at a policy level. So it sounds like Public Policy Committee will definitely be working on that.
Definitely.
That sounds good. So as you think about, we're wrapping up our time together today, but just any final comments or things that you've been reflecting on? We're in this pre-election time, certainly have probably more questions than answers today on some of the Medicare rules. But as you've pointed out, it sounds like we've tried some things that have increased the ability to get care to patients in an efficient manner. So just as we wind up today, final comments or thoughts, Pat?
Maybe more than comments or thoughts is a wish.
That works.
I wish that out of this awful situation that we're in, and given the amount of loss that we've had, and so many individuals and families impacted by this virus and the uncertainty and all that. I just wish that coming out of this would be an acknowledgement that keeping the patient at the center and thinking, again, just practically what makes sense for a person, and not just for a person, but for the healthcare system, what makes practical sense, and to see if anything comes out of this that where we can recognize that this waiver, for example, which one we're talking about, just makes sense. Let's keep it. That's my, and it's probably a naive hope, but I'm going to be naive for a little while. I'm going to be hopeful that we'll get something like that out of this.
Well, I endorse that wish and echo it. What I'm hoping also is that we have some data to support it, because we've had this trial run, and we really look forward to hearing about what the public policy committee comes up with as you do a deeper dive in a less intense time going forward to help direct it.
Yeah, and I'm really glad you brought that up, because we are about to send out a survey to our membership. Speaking of data, and I'm not naive enough to not realize that we absolutely need data. And we can make a contribution to that with the survey that we're going to send out, asking people how they use the waivers, and which ones, they would like to see continue. And that data, at this point, our plan would be to use it in our advocacy efforts on Capitol Hill. So absolutely. And again, that's just a small contribution to I guess the overall hope for the change that we hope is going to come.
Well, we look forward to hearing some results of that and in a future podcast. Today, Pat, I want to thank you for your time today and your insights, both from your experience navigating these past months, as well as the chair of the Public Policy Committee, and reflecting that more national view for those that are participating. So thank you for today.
You're welcome. Thank you for the opportunity.
For the folks that are tuning in today, if you have questions, if you have comments on today's episode, if you have anything you want to follow up with Pat, or if you want to submit a topic for additional for consideration for additional podcasts, please visit acmaweb.org/podcast and send us your thoughts, or you can email us at podcast@acmaweb.org.